So today, my talk, I wanted to have a really broad talk about a range of issues in aging. And as I move through the talk, I'm going to pause occasionally to give people a chance to ask questions. But if there is a burning question that you have while I'm speaking, don't hesitate to put up your hand and ask the question, because it's late in the evening and we've all had dinner, and it's too taxing for your working memory to keep remembering the question, so don't hesitate to ask me. So I'm going to start by talking a little bit about the prevalence of psychiatric conditions in older adults. So basically, the prevalence of mental disorders in older adults ranges from about 15% to 25%. And why is this? Why is there this range of how many older adults are experiencing things like depression and anxiety? And partially that's because some of the statistics will and will not have people in residential aged care included in the statistics. So people who are in residential aged care, as you can see from my slide, much more likely, 70 to 90% of people in institutions are likely to have psychiatric conditions, and that includes dementia. So there's quite a range of people who have these kinds of conditions, and we also have to be mindful of the fact that these are meeting DSM or ICD-10 criteria for mental disorders, and there's many older adults that have subclinical presentations. But at the end of my talk today, I'm starting with pathology because I want to end on healthy aging and positive aging. And I feel that as psychologists, we have a lot to offer people, not just in assessment and treatment of mental disorders, but also in healthy aging, positive aging as well. I participated in an international survey of clinical psychology training programs, and we looked at what were the sorts of topics that were taught about older adults. And there was quite a bit taught about assessment, and not so much taught about treatment, and even less about preventative approaches and healthy aging. And so we have this idea that with older people, our whole goal as psychologists is to spot the problem. And then once we spot the problem, then we don't really have to do too much about it, maybe, because what can we do? And they're older people anyway, and maybe older people, should have or are expected to have more psychiatric problems. And we certainly don't devote a lot of resources, even in training our students, to prevention. But the older population is increasing, and I think we need to pay a lot more attention to interventions and also to preventative strategies. Unfortunately, the last statistic is still true, and it's true across the world that the majority of older adults are not treated. They don't get treatment for their psychiatric disorders. So I guess my goal in life is to try to make sure that that changes. I want to talk a little bit about depression in later life. Depression is probably one of the disorders that's the most studied in later life, but I want to talk about a particular aspect of late life depression, about depression, which is late-onset depression. And late-onset depression is defined as the first instance of a presentation of depressive symptoms after age 60. And so that means that the person was in good mental health before then. And this is a very important distinction because it has a very particular etiology, it has a very particular symptom presentation, and having a late onset of depression has implications then for treatment. So all of these things are quite distinct in this population. I just want to make sure I'm on the right slide. So what is it then to have this first instance of depression later in life? This is more associated than people with an earlier or a chronic presentation of depression in cognitive dysfunction. And we know that when older people present with cognitive dysfunction as a major symptom, what is the first thing that comes to mind as a diagnosis? Dementia, right? And so whereas a younger person presenting with cognitive impairment might get more assessment or more of a workup, older people who present with cognitive impairment later in life, the automatic assumption is dementia, and oftentimes this is not explored at all. People get a mini mental state, they score below 24, and which of course the DSM, the mini mental state, is not a diagnostic instrument, right? So, people get pigeonholed and they don't get the appropriate workup for depression. These people with late onset depression are more likely to have a medical condition, and this makes diagnosis much more tricky. Is the symptom related to this medical condition or the medication that they're taking to treat it, or is it due to depression? The neuroanatomical substrate for late onset depression is much different. People have these kind of neuroanatomical changes like increased ventricular size, cortical atrophy, white matter changes, and they're much more likely to convert to MCI or later dementia. And so there's some speculation that this later onset depression in a certain subset of this population is actually a prodrome or an early symptom of later dementia. Unfortunately, to date, there is really no reliable way to see which older person in later life who has late onset depression is going to go on and have dementia. And even the conversion rates from MCI, some people convert to dementia, and other people actually convert from MCI back to just healthy aging. So there's still a lot of unknowns, even in something that's relatively well studied like late life depression. Unlike people with a chronic history of depression, if you have a family history of the disorder, that's less common. And actually having a family history of the disorder in later life is a better prognostic indicator. So all of these symptoms together, it adds up to a presentation that's very likely to be mistaken for dementia. And so it's very important that you do a detailed clinical interview to be able to separate this from dementia. If you have someone like this in front of you, what are the kinds of things that predict a better response to treatment, whether the treatment is pharmacological or talking therapy? Again, like I said, if the person has a family history of depression, they're actually more likely to respond. Some things that'd be true of anyone, like a more extroverted personality, no history of substance abuse or psychosis, and they're not institutionalized. Obviously, that would help in any kind of diagnostic presentation. But the final factor, high levels of social support, this is very important. In my earlier lecture today, I spent a lot of time talking about social support, the importance of social support in older adults. So in the dementia literature, you have the fact that people who have better social networks are less likely to get dementia. You have, in late onset depression, people who have better social support have a better response to treatment. So what often isn't asked of psychologists is, we're good at giving that 50-minute hour of psychotherapy to people, and active treatment, but what about trying to encourage people's social relationships? I did find some statistics that are specifically Singaporean, that as a population, Singaporeans seem to be less likely to engage in social activities, especially later in life than other groups. So that to me is interesting, since we know from social psychology that participation in social groups helps decrease the risk of cognitive decline and increase the likelihood of emotional well-being. So it's an interesting statistic. We also know some risk factors for depression. So this is a meta-analysis that these sorts of indicators, medical illness, poor health status, bereavement, poor self-perceived health, puts one at risk for depression in later life. Depression in later life has a huge negative impact. So things like suicide, people are familiar with the rates of suicide in later life, particularly among older males. Very high rates of suicide and high rates of suicide completion. More women, older women attempt suicide, more older men actually complete. We have a risk for substance abuse, obviously cognitive impairment, dependence on anxiolytics, and certainly increased healthcare utilization and increased morbidity and mortality. So depression as an illness has a lot of consequences, and unfortunately there's a bias that older adults are more likely to be depressed, but this is a myth, and it's a myth that, that psychologists can help dispel. Even older adults themselves think that maybe it's okay that I feel sad or depressed, and maybe I should just expect that at this time in life, but it's not the case. I think depression is really boring. I'd much rather talk about anxiety. Anxiety is much more exciting than depression, and depression is just kind of depressing. So I'm going to move on to anxiety. This is my area of research. I think it's much more under-researched than depression. So anxiety is actually much more common in older adults. It's much more common than affective disorders, than depression. In some studies, it's more common than severe cognitive impairment. There's a lot of presentation of subthreshold anxiety, and whether or not it reaches a threshold, it very much interferes with quality of life. What are some of the prevalence? Well, these prevalence rates are just as big as those ones. The range is just as big for depression because it depends on how you study, how you measure anxiety, and whether you take into account institutionalized populations. Just like at younger ages, anxiety is more prevalent in women, and it's more prevalent in those with comorbid medical illnesses. And if anything, I think that separating later onset anxiety from dementia is even more difficult, and it's certainly also difficult in the presence of comorbid medical conditions. So what are some of the correlates of anxiety? This is very recent literature trying to say what are the risk factors for anxiety, and also what are the preventative factors for anxiety in later life. So you see these are odds ratios. So certainly the biggest predictor of anxiety in later life is self-rated general health. And self-rated general health in general tends to be highly predictive of morbidity and in some studies mortality in general. Obviously things like anxiolytic use, but the big story in the last 5 or 6 years has been this relationship between earlier trauma, particularly sexual abuse, childhood sexual abuse, and the development of anxiety much later on in life. So there's a lot of research about trauma and the effects of trauma, not so much in older people, not so much especially in older women, but the likelihood that older adults have experienced some trauma, if you're talking about people over 65, the likelihood that they've experienced at least one traumatic event in their life sufficient to potentially have symptoms of PTSD in some studies is as high as 70%. And so it's quite prevalent in this population. What are some things that are sort of protective against anxiety in later life? Things like regular exercise, and again you see, although it's a pretty low odds ratio here, in other studies it's been a little bit higher, and it depends how you measure it, but high perceived social support. So does the person feel, not that they necessarily have a big social network, but do they perceive that they have people that they can confide in and rely on if they have troubles in their life? The higher university education, of course, if everybody's here at JCU, that's good because then you will have less likelihood of anxiety in later life. So always go to university, go to all your classes, never miss class. Of course, education is a marker for SES, so that's why it shows up in all studies. But you should still always show up for class. What are some further correlates of anxiety? Again, it correlates with sort of high blood pressure, vision and hearing loss. This is correlated with symptoms of anxiety. And then what's correlated with actual expression of anxiety disorders is things like, again, self-perceived health problems, functional limitations, and the number of chronic conditions. And I can tell you that from myself, these sorts of things, whether you have medical problems or whether you have chronic conditions that are limiting functionality, tends to be a downward negative spiral in terms of anxiety symptoms, where the more of these things that are experienced, it just tends to exacerbate the symptoms of anxiety. And you see people in both their choices. We know that people with anxiety, they can think they have quite a range of choices. It's hard to do this with the mic. And then your choices go down as you get more anxious. So that feeds into the anxiety, and you tend to withdraw more from social situations. And we know both people with anxiety symptoms and depressive symptoms, after a certain point, it's harder for them to recruit social support because they have symptoms that are, in a sense, pushing people away. And obviously the consequences of late life anxiety, quite severe, high medical costs, high primary care visits. For some statistics out of the United States suggest that people with, for example, generalized anxiety disorder going to their primary physician 1 or more times per week. So it's a huge healthcare cost. It's associated with a range of physical health conditions, mobility and functional limitations, and sleep disturbance. And certainly it increases distress and decreases quality of life. So anxiety is quite a serious complaint. And again, very underdetected. So people who are doing very good screening for a lot of other conditions often won't bother to screen for anxiety. So what makes getting at these relatively common, relatively well understood psychiatric conditions so difficult later in life? I think it's because people don't understand that the expression of the symptoms and how the symptoms are related by clients are different in different populations. So the only people that will come up to you and sort of have this classic, I feel sad and depressed, or I feel anxious in that way. There's sort of maybe people in Woody Allen movies have that kind of presentation, but in real life, children have, the expression of these illnesses is the relationships that they have with their friends and with their peers at school. For older people, the expression of these symptoms is often physical symptoms, and it's often their cognitive status rather than the explicit mood. And oftentimes older adults use different words to say that they're anxious or depressed. They may say, I'm feeling funny, or I don't want to do certain things. They're not really expressing it in the psychological terms that sometimes are looked for. There also may be a lot of stigma against, talking about these conditions, this feeling that I shouldn't have to burden my family with these conditions, or I should be able to cope with this on my own. So there's a reluctance to disclose to healthcare professionals. And finally, when older adults do something like they have an event, say they fall, right, and they might break their hip, then there's very little attention paid to the fact that the person may have incidentally hit their head when they fell, and so they may have memory problems or other kind of cognitive sequelae. They may feel very sad that now their ability to live alone is in jeopardy because they had this event. But all that is kind of secondary to, I must treat the medical condition. And so then it's not a holistic treating of the person, and it tends to have very bad consequences then for the older adult. And psychiatric symptoms are missed. So as I mentioned, either depressed or anxious older adults are more likely to talk about physical symptoms or cognitive symptoms. And they may be unclear, and it may be actually unclear in reality about whether there's shortness of breath, if they have a respiratory condition, do they just have that as a sequelae of their COPD, or are they anxious? Because you can have COPD and be anxious on top of that, right? If you can't breathe, then it's a little bit anxiety provoking. If people are taking medication that causes rapid heartbeat, again, it can be very easily mistaken for, is it the anxiety or is it the medication? It's very hard to parcel these things out. And the cognitive decline that you would see in any age, people who are depressed or anxious at any age will have a decrease in cognitive functioning. But oftentimes people just jump to the conclusion that it's dementia without giving a thorough assessment of actually the person's cognitive functioning. And I'll talk a little bit later in the talk about capacity assessment. I don't know if capacity assessment, I'm sure it's an issue here. But a lot of times somebody who is depressed will be seen as having lack of capacity. And then even if they got treatment for the depression, which then should mean that their cognitive capacity goes back up, they're often not reassessed. And even in the case of somebody with a MCI, their MCI symptoms could remit. And then again, the question of whether they have the capacity to dictate their own health or other financial, say, desires, it's not reevaluated. So we really need to look at this quite fine-grained, and we also need to understand that sometimes things get worse for older adults, but sometimes they get better too, right? So we have to be sensitive to that from a measurement perspective. Some of this I've already said. Subsyndromal presentations of anxiety disorders are quite common. And so I think that that's something that you should be mindful of. And again, there is this kind of acceptance among health professionals that screening for anxiety is not routine, and it doesn't need to be, because there's this myth of older people being more anxious in later life. And I think because of that stigma, or this kind of slightly ageist perspective, in the phrasing of questions that are supposed to be meant to be getting at anxiety, people will just accept that whatever the older person is telling them, of course that must be true because they're older. So if you were to say, for example, well, do you like to get out and see your friends? And the older person says, no, I really prefer to stay at home. If it was a younger person, you would say, well, maybe this is a red flag. But it's an older person who says, oh, yes, well, they probably should just stay home, right? And there's this idea that that's normal, right? And so you really need to be asking much more probing questions of the older person. And you have to have, you cannot be treating older adults unless you have a really good idea of what is the norm for an older adult of 65, 75, 85, 95, right? You need to understand what those people are capable of physically, mentally, socially. If you think all older adults are the same, if you have very truncated expectations for what older people will do, right, then you will accept as normal what is actually very abnormal behavior. Not going out and seeing people, staying at home, being reclusive, right? Having a set of phobias or fears, right, that are quite inappropriate, whatever the age is, but you're accepting that as normal and not treating a very treatable condition. The other thing is comorbidity. There's a high level of comorbidity between anxiety, depression in later life. So the typical ratio is that about half of the people with depression in later life have anxiety, and about a quarter of those with anxiety also have depression. And earlier today, I was asked the question about, what might I treat first in an older adult with a constellation of symptoms? And there's some intriguing work that says it doesn't matter, like there's not one right answer, like you should always treat the depression or you should always treat the anxiety. It probably has more to do with what is most distressing to the person themselves. And there's some evidence that if you do a good course of psychological treatment for, say, depression, then there'll be knock-on effects for the anxiety. I'll say, are there any questions? I'll just press on. Okay. So I'll talk a little bit about assessment with older clients. Sometimes it's very difficult to get information from older people. And earlier today, people said that one of the difficulties in interviewing older adults might be language issues. Are people experiencing that? Yeah. So that's a very difficult issue. Do you have access to translators here in the course of doing interviews? Yeah. I mean, certainly in Australia, a very multicultural population, we often have difficulties with language. But even if the language is the same, you may have a lot of difficulty getting information out of people. People with cognitive impairment won't be able to give you good information. They may be fatigued or distressed. They may have family, maybe a dysfunctional family that may be telling you all sorts of different things. So it can be very difficult to get this information. And my advice as a geropsychologist would be to try to persevere. Try to persevere and get as much information as you can about an older person from as many different people as you can that is reasonable, but also ask the older person themselves about what they're feeling about the situation, or as much information as you can. So the more information you can get, the better. The other thing, though, so that's getting the information, like the clinical interview. For my money, even speaking as a neuropsychologist, there's no test of cognitive functioning or emotional functioning that takes the place of a solid, thorough clinical interview, right? So if I was to give one piece I'm always asked, what's the best test, right? And I don't know if there's any one answer for that for any disorder, but there's no substitute for a thorough clinical interview. So when a student would come to me and say, well, I gave this beautiful, 10-hour cognitive assessment, I assessed everything under the sun, and I say, right, did you do a depression screen? No. Well, what do you know? Right? 10 hours worth of testing, and you don't know the simple question about whether that person is depressed, right? So you have to do that thorough clinical interview so you can answer those questions. The other thing is, I think that there's often unnecessary or over referrals. We're seeing a lot of this in Brisbane. For every single thing that has to happen with an older adult, they're asking all these questions about capacity, and there's a lot of over assessment. And again, I would say that you want to really hone your assessment for the question that's in front of you, right? Giving very long batteries, starting with the Wechsler Adult Intelligence Scale, is probably not what I would recommend, right? I would recommend starting with what's being presented as the referral question and doing a very targeted assessment with a limited battery of well-validated instruments that would then be complemented by your clinical interview to give the best possible either diagnostic information or information for a treatment plan. I will say, because I'm speaking in Singapore, that you need to make sure that you have good normative data, that it's been translated well into whatever language you're using, and there's a good solid psychometric literature behind whatever assessment instrument you choose. So this is an example of the importance of the clinical interview. So say you want to determine whether or not the person has generalized anxiety disorder, right? And that's characterized by excessive worry. But you have in your mind that, of course, all older adults worry about everything. So you don't ask probing questions. So these are good examples of probing questions. Do your healthcare providers say that you worry too much? Do you think you check things like whatever? More than not, not just accepting what the person's saying, but doing a little bit more probing. I mean, for me, the classic illustration of this is for substance abuse, right? Standardized instruments meant to measure substance abuse ask questions like, to know if you're drinking too much, to say, does your drinking interfere with work? And of course, retired people say, no, never interferes with work, right? So that's not a good question. Right? So you have to ask questions that are appropriate to the person's age and context. And you do have to have, and this is what I was saying before, age-specific examples of maladaptive avoidance, so not using public transportation, due to, say, an excessive fear of falling, which is a particular type of anxiety, fear of falling. Older adults have one fall or a near miss, and then they start this whole series of pathological behavior to avoid falls, with the collusion of sometimes of healthcare professionals and family who also become obsessed with falls. So all this does is limit functionality and actually increases the risk of falls. I will spend a moment shamelessly plugging my own instrument, the Geriatric Anxiety Inventory, which is being used here in Singapore. And we actually have I don't know if people are aware of the International Congress of Psychology that's happening in Japan in July. Yeah. So actually we have a presentation about the GAI there. But the Geriatric Anxiety Inventory is developed at UQ with my colleague Jared Byrne, and it's a brief 20-item self-report symptom inventory, which is patterned on the Geriatric Depression Scale, and it's to measure anxiety. And I will say this, along with a lot of screening instruments. I'm a great fan of screening instruments, but they're not for diagnosis, right? The MMSE is not a diagnostic instrument. This scale is not a diagnostic instrument, right? It's a symptom severity scale. It certainly gives you a good indication if somebody scores highly that maybe you should do a standardized clinical interview to get a diagnosis, but it itself is not diagnostic. And this is the GAI in very small print so that you can't see it. You always have to have a slide that no one can read. So this is my slide that no one can read. And it comes in, I'll say that it also comes in a short version. Is there anybody here who's ever used this in their clinical work? So fertile green fields. So If anybody, I have my email at the end. If anyone would like any information about the GAI, I'm happy to send it along. Okay, I'm going to talk a little bit about the efficacy of psychotherapy with older adults, which is really, really high, which is why it is so unfortunate that many older adults do not get psychological treatments for disorders. For older adults, say for treatment for depression, even when they have pretty profound cognitive impairment, you have like an 80% response rate, and most people who do get treatment for, say, late-onset depression go back to or very close to a prior level of cognitive functioning. But unfortunately, people are not getting this training. There's been a lot of research on cognitive behavioral therapy, but I'll say that there are a lot of therapeutic approaches that also have an evidence base. So relaxation training, supportive therapy, interpersonal therapy, problem-solving therapy, and brief psychodynamic therapy all have an evidence base specifically in older people. I will say that across these studies, there is a bit of a tendency for older adults to have a higher relapse rate than, say, middle-aged adults. And I think that this may be partially due to people not pursuing the treatment as it was designed. In the pharmacology literature, you will have a non-response rate among older adults in both psychiatric and non-psychiatric conditions because the medications are not given as they were meant to be prescribed, either in a sufficient dose or for long enough, right? And I think the same is true with psychological approaches. Sometimes, even among my colleagues, like when I came to the University of Queensland, no one else did aging. And they said to me, Nancy, when you do CBT, you don't make older people fill out all those forms, do you? You don't make them do homework. Can older people do homework? Like, this is silly questions. I mean, the whole purpose of cognitive behavioral therapy is that you do monitoring of symptoms and you give people things to fill out at home, pleasant event inventories or whatever, right? And you have to make it relevant to the older person. You have to make sure that it's titrated to whatever their reading level or whatever they're at. But you certainly do those things. And so I think there's some speculation. There's a number of reasons for this kind of relapse rate. One is I don't think that the therapies are given as designed. And two, I think that sometimes we talked a little bit about comorbidities or medical conditions. So people miss sessions. They have to go for longer. There's constraints, though, in the healthcare system, right? Who's paying for this? You know, what is the access to psychologists? So there's a lot of barriers for people getting what I would say is a therapeutic dose of the intervention. So I think that if you are treating an older person, that you have to be sensitive to these issues, and you have to really say, am I giving this at a therapeutic dose for long enough before you say that the person is treatment resistant? And this is probably the better way to prevent relapse. Another tip for preventing relapse, I think, is to, at the end of therapy, to make sure that you give the person resources, right, so that they can take those resources. What were the things in the therapy that worked best for the person, so that they can take that forward after they leave you. And I have at the bottom there interdisciplinary or interprofessional treatment models are very effective with older adults, especially with comorbid medical conditions. So having many kinds of health professionals involved in giving the treatment is definitely results in better outcomes. So as I've said, the high rates of improvement. Certainly, if there's a higher sort of severity of the depression, CBT plus medication definitely tends to have better outcomes than either alone. Although some of that disappears at follow-up. It depends on how long the follow-up is. Unfortunately, due to this comorbidity of anxiety and depression, it is the case that if you have comorbid anxiety with depression, people do have a poorer treatment response and they do tend to drop out. Also, the older adults with that level of anxiety tend to take longer to respond to treatment. they're also at greater risk for suicidal ideation and attempts. And it's interesting, there's a large Dutch study that asked healthcare professionals, which do you think basically is at the higher risk for suicide, people with depression or people with anxiety? And somehow they felt that people with anxiety were at less risk for suicide. And actually it was found that in looking at this data for completion rates, they're actually a slightly higher risk of completing suicide. So again, I think this is this misunderstanding of the dangers of anxiety in later life. Again, this is more Dutch research on the treatment of anxiety in later life, and again, really, robust effect sizes for CBT in anxious older adults. But again, anxious older adults are among the least likely to receive these treatments. A lot of times I'm asked, like, what are the differences in treating younger adults and older adults, and do I have to really adapt my therapy? And if I haven't received extensive training in treating older adults, can I still treat older adults? How different are older adults? And so it's interesting because it's a tricky question, because you don't want to say that older adults are like a different species. It's like they're over there and they're a different species, right? So a 75-year-old, highly verbal, articulate older adult can be indistinguishable from, say, a 50-year-old. And you can have someone, relatively young old person, or even someone in their 60s, early 60s, who has multiple comorbid medical conditions and a lower level of functionality that can really be in the therapy like a much older person. And so there's a lot of overlap with mid-aged adults in terms of what you would do in terms of treatment. But I think that the main thing to remember when you are treating people over 65 is that they are very individual. The research is very clear that for treating a range of conditions, including substance abuse and whatnot, that tailoring the therapy to the person is probably best. The other thing is that you have to recognize that there may be cohort effects, and it could be language, it could be where the person, their early life experiences, whatever, that may make it more or less difficult to establish the therapeutic relationship or to somehow have other barriers to the therapy. And I think that that's probably, it's a matter of technique, but it's also a matter of tailoring the therapy to the person in front of you. So I would say that even if you haven't had extensive treatment experience with older adults, you can certainly attempt that. But it is a good idea to get supervision. We do find in the therapy literature that the efficacy rates for therapy with older adults go up if you have either supervision or pedagogical training in working with older adults, right? So, and that's not the case with working with children, interestingly. So I would urge people to, include older adults in their practice, but certainly learning about older adults, participating in workshops like today and whatnot, will increase your therapeutic efficacy. It's one of the reasons why at UQ, as part of the standard training, we just have a course in working with older adults, and it's partly a response to demographics, but it's partly in response to that efficacy of treatment, that we know that providing such a course will help in treatment efficacy. Go on. Okay. So I wanted to talk a little bit about also dementia and screening for cognitive impairment. So I know from my earlier talk today that people are using these sorts of instruments. Here in Singapore, people are using the MOCA or dementia rating scale or some sort of version of an extended or standardized MMSE. And again, there's no one universal screen that's important, but I do think that using a screen like this can be very important, even if you're just doing psychotherapy with an older adult, because sometimes the older adult can present very well in an interpersonal way, but have cognitive issues such that you'd want to change what you were doing therapeutically if you actually had a MOCA score in front of you. Also, if the person is depressed and they're having a lot of cognitive impairment, if you get a baseline cognitive screening score, then you can compare how the person's doing at the beginning of treatment with how they're doing at the end. I do want to talk a little bit about capacity. Is capacity assessment an issue here in Singapore? Assessing for capacity? Is that something that psychologists do? Probably, possibly.
It's going to happen, I think.
It's going to happen. Okay.
I think being aware now that there's this great possibility because we have a tourist guide who came and treat the elderly lady millions and millions.
Wow.
So now they begin to recognize that there are people who are incapacitated, and how are you going to stand enduring with her?
So then there's the issue. So what we're saying is that so there's the issue both of does the person themselves have capacity to make healthcare conditions or financial decisions, but also is the person vulnerable to abuse? Right, okay. So how do you determine that? I think, again, in the capacity literature, there's a lot of biases about older people, that older people can't make their own decisions, or what am I looking for as a marker of what is the hallmark of somebody who can't make decisions. So I was at a workshop where we were discussing capacity, and it was a very young psychiatrist that was in charge of the workshop. And he said to me, Nancy, I'm going to present a picture of this older person. It's an older person and they're living alone, he said, as though no one who's older lives alone. They were living alone, and and they had a fall, and then there were all kinds of problems after this fall. And on top of that, they had 6 cats. This older woman had 6 cats. And he said to me, Dr. Pachana, what do you think about this person's mental capacity? And I took the microphone and I said, I have 6 cats. So what do you think about my mental capacity? I said, I'm unaware of that part of the DSM that says 6 cats is diagnostic for any particular condition. And it's really extraordinary to me. It seems very clear to me that if you have, in Australia, do you know in Australia they're very fond of garden gnomes in their garden, these little statues? It's very clear that you can have as many as you want until you're 65. Because then that may be a very pathological sign. We have this idea, these stereotypes in our head, and it leads to decisions. I had a healthcare professional at the same workshop. She was a podiatrist, and she said, I told this older gentleman to wash his feet in something, and he didn't follow my instructions, so clearly he lacked capacity. I said, really? Someone goes to a health professional like, a dentist, and the dentist says to do something like, floss your teeth, and you don't do it. All those people lack capacity. So again, no agency on the part of the older person, that the older person has the capability to make a decision that you might not agree with. So I think this is very dangerous for older people, because once you take away a person's capacity, then it's very rare that the person gets it back, and it has a lot of knock-on effects. But we want to be protecting people who may be vulnerable to abuse. But the literature is very clear, just like it's clear in the driving literature, that an older person who is cognitively and physically intact is not at risk for having an accident, that older adults are very good drivers, and that in terms of being sucked up in like a scam or being taken advantage of, that if an older person is cognitively and physically healthy, they are less likely to buy the Brooklyn Bridge than a person at any age who is compromised. So what are we looking for? So we're looking for that kind of cognitive and physical compromise, and we're being guided by that in our interview, not in stereotypes of what constitutes strange behavior. So in the slide here, I say this strange or ill-conceived behavior, or this kind of stereotype that an older person should just do as I say, as the healthcare professional. These are very dangerous kinds of stereotypes. People can also have dementia and have capacity. They can have the capacity to express simple desires, right? They can have the capacity to understand whether or not they want to undertake medical procedures if they're described well. So just having dementia doesn't mean that you lack capacity. Just the other day I read under review an article where in California where they had systematically tested people with dementia as to whether they could consent to being in drug trials, pharmacy trials. And they found that about a quarter of the people with dementia actually had the capacity to give consent to be in a relatively complex level 2 pharma trial, just completely on their own, like they didn't have to rely on their caregiver. So again, we have to just not accept the fact that dementia will make somebody unable to have capacity. I think that's all I want to say about capacity. So that's all I want to say about capacity. That's my little rant on capacity. I thought I would talk a little bit about cognitive training. How many people have heard about Luminosity and the lawsuit against, Luminosity? Luminosity is that great program on the internet where you do little games, and neuroscience has shown that it helps your brain. So why is Luminosity being sued? Luminosity is not being sued because doing cognitive engagement and cognitive training doesn't help your brain. Like there's lots of studies that show that maintaining cognitive engagement helps your memory. In certain studies, it helps stave off depression. But the Luminosity suit is kind of linked to our earlier discussion about capacity and being taken advantage of. Because if you're older, the salience of dementia in the media is very high. And if you have a family member that you suspect or has been diagnosed with having dementia, we have no treatment for dementia at the current time. So then anything that presents itself as possibly decreasing cognitive impairment is seized upon. And Luminosity was charging a pretty healthy amount per month for access to this. And it was saying that it was underpinned by a literature where that literature didn't really support it. But the idea of having some kind of cognitive engagement, just like the idea of social engagement, I think is really important. So when we talk about cognitive training, I think this is an area where, again, psychology can contribute a lot. And it's any of a number of approaches that are aimed at improving cognition, regardless of what the method of action is. And I would say regardless of whether or not how structured it is or how targeted it is to a particular area of cognitive functioning. So a lot of times it'll focus on a particular area like memory, or for example, it might target a non-cognitive area like social skills. So for example, older adults with schizophrenia, older adults, the aging population actually are people with autistic spectrum disorders. There, some targeted remediation in social skills can be really helpful. But the big problem with this literature in general is that if you target any cognitive area, you get very little generalization. So you train people on how to, make their memory better, and it works for whatever you train them on, but it won't help them find their way or get dressed in the morning, or it won't help them do anything functional in the real world, and this is a problem. So how can we get around this? Well, one of the things you can do is you can say, what is the amount of formal cognitive training versus everything else that's around the person? So if I come and give my very, very fancy cognitive training routine to the person for 20 minutes, 3 times a day, and the whole rest of the time they're completely unengaged in anything meaningful, right? If they're wrapped up in cotton wool and their family won't let them do things, if we do what we do in nursing homes and make people incredibly passive, then I don't think that my intervention is going to have a very good effect. If we look, for example, at what they're doing in the Netherlands in nursing homes, what do they have people do? They don't have a lot of fancy cognitive remediation, but they have people get up in the morning and the people with dementia help make breakfast. And then they help clear the dishes. And then they help with the laundry. And then they help with lunch, right? So they do things that's in their programmed repertoire. They have cues or assistants to help them do that. And these are meaningful activities that help in their unit or whatever throughout the day, right? So to me, those are major components of a meaningful cognitive stimulation program that can be pretty informal, but can have pretty good positive effects. So how can you do this? Can the person continue activities that they've done in the past, maybe with a little more structure or with prompts? Yeah, are these personally meaningful activities, or are you going to have everyone do like macrame or something that nobody wants to do? Are there other people in the environment that are creating barriers? So are there other people that are saying that the person can't do it, or giving some kind of signals that the person can't do it? And is the person doing this in a way that they're engaged with other people, and is their emotional well-being being catered to at the same time? Because no matter how severe your dementia is, people with dementia or cognitive impairment are very tuned to nonverbal cues and cues in your voice that give a message that you really shouldn't be doing that, or you're not really valued in your participation, and I think that that's really key. The other thing, again, is I'll stress this idea of social relationships. So if sitting is the new smoking, then I think not having social relationships is sitting and smoking. So because the studies suggest that if you don't have adequate social relationships, then your survival rates, full stop, are not that great. And the benefits of having social support are comparable to quitting smoking or, having exercise and so forth. So the social component is really critical. So again, if people are designing cognitive remediation programs for older adults, I think they have to ask, what is the social milieu of that person, and not isolate that from what you're trying to do cognitively. Yeah, this is the statistic that I found with Singapore in terms of that is, I don't know, I'm not sure about that event, but it's this idea that community participation is less in people in Singapore. And I thought that was quite interesting, because I was also asked, how do you get older adults to participate in, say, cognitive remediation tasks? And if it's not kind of in the social DNA to do that, then it's very difficult. Or if people haven't their whole life participated in groups, then it's very difficult for people to get people to do that later in life. The other thing that's been a big topic in the cognitive remediation literature, just like it has been in the psychotherapy literature, is there a multimodal approach that could help augment treatment efficacy? So here's a whole bunch of other things that you can pair with a cognitive stimulation approach that could boost efficacy. So for example, you could say, what is the person's nutrition? Especially if people are older and living alone, they often have compromised nutrition. I don't know the statistics for Singapore, but in Australia, huge numbers of people who live in residential aged care have malnourishment. They're just not getting their nutritional needs met. What about sleep hygiene? People not sleeping has a huge impact on cognitive functioning. Older adults, about 50% of older adults have disturbed sleep. Older adults have more trouble falling asleep. They don't stay as long in REM sleep. They don't get the same level of quality of sleep. And what some studies have shown is that if you can improve that sleep even a little bit, you will get concomitant increases in cognitive functioning, right? So again, I think to ignore this or to stop older adults from having, a lot of older adults don't know about sleep hygiene. They don't know about the effects of caffeine or things like that. I had myself an older woman who came to me and she said I had terrible sleep. And I said, what do you do at night? She goes, well, I drink a couple glasses of sherry. And then she did all this stuff in bed, which you're not supposed to do, right? And then she said, and then I drink half a liter of Coke before I go to bed. And I was like, really? I said, I think that has a lot of caffeine, doesn't it? And she goes, no, I don't think Coke has caffeine. I'm like, I'm pretty sure Coke has caffeine. So, you really don't understand what people are doing that are very interfering with sleep. Are people doing things that are meaningful? A lot of times, just like activities are being prescribed by psychologists who are doing, say, CBT plus exercise. So you can kind of prescribe these sort of, are you doing something meaningful, some activity, volunteering, and so forth. which can, again, increase not only mood and stuff, but I think it could have an effect on cognition as well. There's also some intriguing data on CBT approaches for people with mild cognitive impairment that involve family in the therapy. And so you have the family coming to some of the sessions to reinforce what you're trying to say to the person about relaxation or about any of the therapeutic points, so that the family themselves can reinforce that with the person with cognitive impairment and help support that. And again, it boosts efficacy in CBT with these populations. So I think that this kind of multimodal approach, paired with whether it's a targeted cognitive remediation treatment or just a sort of incidental cognitive remediation of getting the person engaged in activity, I think that this can help a lot with efficacy. And because it came up in an earlier group, many people were describing to me at an earlier talk today running like a cognitive stimulation group, but running the group with people with varying levels of cognition. So how would you do that with people in the same group with mild, moderate, and more severe cognitive impairment? I think that anybody who's run a group realizes the difficulty in that, right? Because you've got people at different stages. I think that then what you have to do is state explicitly in this group, so I'm assuming like it's an open group, people can come and join at any time, but you don't kick anybody out of the group, is to make that explicit, to say, we're in this group and we have people of different levels of cognitive impairment, and you give people permission to help others and be helped, right? So then, since that's explicit, then you don't have people having this, I don't say anything when the person needs help, or if they're disruptive, I feel angry about that. I do say, and I will say, because I work a lot with my particular population at the moment is people with Parkinson's disease. And although people with Parkinson's disease will do a lot of stuff, they are somewhat tentative about joining a group if it has people with much more progressed symptoms of the Parkinsonism than where they are. Because it's a very salient reminder of where they may be in a few months or a few years. So I think it's a delicate balance between having an inclusive stance in the group and also running the group in such a way that you can genuinely get cognitive or emotional outcomes that you want and not freaking people out. And so I would never say it's an easy thing. You should always have a co-therapist, though, because groups can be vicious. They can turn on you. And it's much better to have a co-therapist there as well. Seriously, so that they may be able to, if you're busy running one portion of the group, they can notice what's happening in another portion of the group and alert you to that. So I'm going to talk a little bit, just a couple minutes about dementia. This is my typical slide that I show to show the symptoms of behavioral and psychological symptoms of dementia. This is the point of diagnosis. These are the symptoms that happen after diagnosis. This is the 40-month prodrome before the person receives the diagnosis. Most people are receiving a diagnosis maybe slightly earlier, but it's still after quite a few symptoms are going on. And what you see is that this is kind of the early sort of depression and social withdrawal when people are just having some symptoms, but it's really unexplained. Maybe sliding into some more anxious and paranoid BPSD closer to the point of diagnosis, maybe when the person themselves and those around them are becoming aware of the potential for dementia. And then you have symptoms like hallucinations and delusions that are really associated with more advanced symptoms post-diagnosis. I will say that any of these symptoms on this side of the diagnostic line are probably a poor prognostic indicator and probably an indicator of more severe trajectory of decline. So this is just to reinforce the fact that behavioral and psychological symptoms associated with dementia are linked to the time and stage of the dementia. And even if you solve something like somebody's paranoia or anxiety at an earlier point, the disease continues to progress, new symptoms will continue to come up, and whether it's an informal or a formal caregiver, they're going to have to continue to be creative to solve these problems. And what do you need to do? Why is it very important to figure out why the person is having these symptoms? I think it's very important to figure this out, whether you do it through observation or through actual inventories, because you need to understand why the person is having the symptom at that point of time, before you can really prescribe any kind of intervention. So this is what I give to both professional and family caregivers to go through to try to understand why the person is having that symptom at that particular time. So are they aggressive? For example, let's say the symptom is aggression. Are they having this aggression because they have a physical problem, or they're in discomfort, like they have pain, because their cognitive changes are so profound that they really don't understand what's going on around them, because they're, say, depressed or anxious, because they have sensory impairments, like they have visual or hearing impairments that are really making it difficult to interact with the environment. There's something in the environment that's making it very uncomfortable for them. Maybe it's a noisy environment or it's a confusing environment. And are there social or cultural factors? Like, is the person in an institutional setting such that they're not able to do the cultural and social things that will make them content? So this piece is from Canada, and it's a well-validated, very easy, you can tell this to nurses and nursing assistants, to just go through this checklist to try to figure out what might be causing the person's problems. I'm going to skip that. The other thing is that if the person, if someone knows the person with dementia well, they may be able to tell you something very simple that will be able to give that person comfort. But a lot of times people with dementia are cared for by people that don't know them very well. And so again, this is from a US nursing study, that you put these top 5 strategies with the person to ensure personalized care. And what does this look like? This top 5 strategy can be something very simple. This older woman tends to get very cold. So if she doesn't have her sweater, and she's calling out, try to just give her her sweater. She's also a very modest lady, and so she would prefer that her self-cares are done not by a male. So try to get a female attendant. So just something like that, like it's 2 or 3 lines on an index card. It can really help make the person's care very targeted to what is important to that person. Otherwise, nobody knows about her sweater. Nobody knows she gets cold, right? And for that day, she gets a real increase in psychotropic medication just for the loss of that simple piece of information. Let me skip this. I want to just end a little bit on dementia prevention. So there's a whole bunch of things that we know about, lifestyle factors, that can help people decrease their risk of getting dementia. Keeping physically and mentally active and keeping socially active all can decrease the risk of dementia. And dementia is such a profound diagnosis, and older people can feel quite helpless. It's really important to get a sense that people can do things that will help them prevent dementia. So, pursuing hobbies, maintaining social contacts, going for regular health checks, all can help with dementia prevention. And this is very important information, because this is about leisure activities in dementia. And so there's lots of things like board games, playing a musical instrument, and dancing that are very good at preventing dementia. But you notice that housework is not. So you should totally outsource all housework, because it will not do anything in helping your dementia. There's also lots of things that lead to better or worse life expectancy. So this is the amount of years of living that can change based on these activities, how much you lose, and or how much you can gain in terms of things like exercise or regular medical checkups, low-fat, high-nutrition diet. There are a lot of these that are available on the internet. If you would like to calculate exactly how long you will live, you should go and do things that are called a longevity calculator. And it will ask you about behaviors. And this is eventually what led me to giving up crumbed sausages. which I used to eat all the time when I first came to Queensland. And actually, on several of those, it actually said, how many sausages do you eat a week? So I did give them up in the interest of longevity. And the other thing is positive aging is not just something that happens. It's not just good genes. Sometimes you'll have patients come to you for psychotherapy that had a parent die at a very young age. And when it gets to be that age for them, then they kind of reflect on that and they get very depressed, or they think that it's inevitable that their life will also be shortened. And they don't really understand, that medical advances have happened, but that there's also, each person is different, and you're not kind of sort of a prisoner to your genetic makeup, There's lots of things about aging that we can help facilitate, that help determine the quality of our lives, that are under our own control. And so we really should remember that and also share that information with our clients. Simple things like volunteering, right? This shows that, even for people who are not doing so well in terms of functionality, that volunteering, helped across a lot of domains, particularly mood and giving meaning to life and social contacts. So it's really important. This is the last thing I'll say, which is really, what is the goal of being a psychologist who works with older adults? It really, even in nursing homes, it should be that you're contributing to fundamental change that really render such places as authentic places where people can actualize their potentials for positive mental health, living with dignity, enhancing their well-being, and living creatively. And this is from some researchers in Israel who particularly research nursing homes. But I would say that that's the goal for all older people, whether they're living in an institution or not, is for psychologists to help them reach their full potential and overcome barriers. This is me. People who are familiar with older adults and aged care will know that this is Paru the seal. They actually have a range of these kinds of therapy animals in play. I think for myself, it's a real privilege always to work with older adults. I would really like to encourage younger people to work with older adults, because I think if you want to have efficacy as a psychologist, working with older adults is one of the best ways to have efficacy, and really see yourself as valued by a team and by older people's family and the older adults themselves. I run a listserv run by my Aging Mind Initiative. It's a free listserv that you can join, and I can send you a weekly update on aging research. And I'd be very happy if anybody in the audience, I love getting emails. I get emails from most of Australia. I'd love to get emails from most of Singapore. And it's free to join. So that's the end of my talk. You've been a really patient and attentive audience. I want to thank you very much for inviting me here today. And I'm happy to take questions. Thank you.